Hello and welcome. Today I will talk about Achalasia Cardia. What is Achalasia Cardia? It is an esophageal motility disorder characterized by eperistalsis of the body of the esophagus and failure of relaxation of the lower end of the esophagus. Its incidence is about 1 in 1 lakh annually. So quite rare indeed. Now the pathogenesis of the disease, we can remember 4 points. The number 1, that is degeneration of the ganglionic neuron of the myotic plexus or Orbach plexus. What is myotic plexus or Orbach plexus? This plexus lies in between the inner circular layer and outer longitudinal muscular layer of the esophageal wall. So number 1 is the degeneration of the ganglionic neuron of the myotic plexus or Orbach plexus. Number 2, failure of peristalsis of the esophagus. Number 3, failure of relaxation of the lower end of the esophagus. Number 4, increased resting tone of the lower end of the esophagus. Now, the Achalasia Cardia can be divided into 2 types, the primary type and the secondary type. The primary type is of idiopathic variety, and the secondary type can be caused by, number 1, Chagas disease. This disease is caused by a protozoa called Trypanosoma cruzi. In this disease, the ganglionic neurons of the myotic plexus are damaged, and it can occur secondarily after anti-reflux surgery when the fundoplication wrap is too tight. Now, what are the complaints patient present with? Number 1, there is dysphagia to liquid. Remember it, there is dysphagia to liquid substance primarily, which is inverse to esophageal carcinoma, in which there is dysphagia to solid. Number 2, as there is dysphagia, there is regurgitation of the food bolus, and as there is regurgitation, there is aspiration. And there may be retrosternal chest pain. It occurs in vigorous achalasia. What is vigorous achalasia? In some variety of achalasia, the normal part of the esophagus contracts vigorously to overcome the increased lower esophageal sphincter tone. So retrosternal chest pain occurs. This is called vigorous achalasia. In the long run, the patient may complain of weight loss. There may be chronic cough, hiccup, there may be heartburn, globus sensation. So how can we investigate a case of Achalasia Cardia? Number 1, we can do flexible endoscopy to differentiate whether it is esophageal carcinoma or Achalasia Cardia. In flexible endoscopy, we will find that there is dilated esophagus, there is closed lower end of the esophagus, and food particles may be seen in the esophagus. Number 2, we can do barium swallow X-ray. In barium swallow X-ray, we will see that dilated esophagus or mega esophagus with rat tail lower end, also called bird beak appearance. This is seen in lower 2/3 of the esophagus. Number 3 is the esophageal manometry test. This is the confirmatory test. In this test, we will see that there is decreased intraesophageal pressure and increased pressure at the lower end of the esophagus that may be more than 40 mm mercury. What are the complications that may arise if we do not treat Achalasia Cardia? There can be recurrent aspiration and recurrent pneumonia-like symptoms, and it may turn into carcinoma. It is a pre-malignant condition, so it can turn into carcinoma in the long run, mainly squamous cell carcinoma due to irritation of the food particles, and there can also occur adenocarcinoma, especially after surgery when there develops gastroesophageal reflux. Then the lower end of the esophagus is predisposed to adenocarcinoma in the long run. Now come to the treatment. At number 1, we can do endoscopic balloon dilatation or graded pneumatic dilatation, because it is done by stages. First, we can do dilatation by 30 mm size. First, we can do dilatation by 30 mm size balloon. Then after several weeks, we can use 35 mm size balloon. Then after several weeks, we can use 40 mm size balloon. This is graded dilatation. A small risk of esophageal perforation remains here, only 5% cases. And number 2, that is Heller's modified cardiomyotomy operation. This is the definitive surgery. It can be done laparoscopically, and some surgeons do a fundoplication operation with it to prevent reflux. Number 3, there is another option, that is the injection of botulinum toxin in the lower end of the esophagus. But this is not a permanent solution. This is only for temporary basis. It's needs to be repeated every 2 years, and this can only be applied to the patients who cannot undergo surgery. There are some drug treatments also, like calcium channel blockers or nitrates. These are also temporary measures, not a permanent one, and also for reserved for those patients who are not eligible for undergoing surgery. Hope you have enjoyed. Thanks for watching. Goodbye.